Module T, Dementia and Alzheimer's disease. In this module, we're going to define the terms dementia, Alzheimer's disease, and delirium. And we're going to describe the nurse aide's role in caring for the resident with Alzheimer's. So dementia is a progressive condition marked by the development of multiple cognitive deficits, such as memory impairment, aphasia, and an inability to plan and initiate complex behavior. Aphasia, with an S, is a difficulty in speaking or an inability to speak. So there are 4 types of dementia. There's Alzheimer's disease, which is the most common cause of dementia, thought to be caused by clumps of protein, referred to as tangles in the brain. Vascular dementia occurs when blood circulation to the brain decreases as a result of a stroke or another problem, another vascular problem, damaging blood vessels in the brain. Dementia with Lewy bodies. These are deposits of protein that develop throughout the brain, and these protein deposits damage or kill nerves in the brain over time. Lewy body dementia is a newer dementia diagnosis, but it is becoming more common. And of course, mixed dementia is when somebody would have maybe a combination of these two. Maybe they've got Alzheimer's disease, but they've also had a stroke, so they've got vascular dementia on top of that. So mixed dementia would be a combination of one or more of these different types of dementias. So let me clarify. Alzheimer's disease is a type of dementia. Dementia is the big umbrella, and these are the types of dementia that fall under that umbrella. So let's talk about a little bit more about Alzheimer's disease. It is a progressive disease. There is no cure. It is very gradual, but it is based on the person's disease process. So everybody's disease will progress at its own rate. We do not have the ability to say, well, if you have Alzheimer's disease, this is what's going to happen in year 1, this is going to happen in year 2. We don't have that ability. Some people are diagnosed with Alzheimer's disease and they live for a long period of time and have very, very slow progression. Other people, their progression is very quickly. So it's very fast. So we don't know how quickly it's going to go. But it is a gradual decline in memory, thinking, and physical ability over the period of several years. The average lifespan for somebody who's diagnosed with Alzheimer's is 8 years, but survival may be from 3 years to 20 years. And the reason for that is people aren't usually diagnosed with Alzheimer's until they're in one of the middle stages. So it really depends on how early you're diagnosed with Alzheimer's. Some people are diagnosed very, very late, and their disease process progresses very quickly. Or maybe they're diagnosed very early and their disease process progresses very slowly. So that's why there's such a wide range, that 3 to years. But overall, the general lifespan of somebody who's diagnosed with Alzheimer's is 8 years. It progresses into 7 stages. It used to just be the 3 stages of Alzheimer's. It is now 7. So if you have an older book and it talks about the 3, you need to pay attention to the PowerPoints. So let's talk about the 7 stages of Alzheimer's. Stage 1 is no impairment. The disease is not evident. There's no memory problems. The person doesn't even really know that they've got it going on. So it's not even apparent to the person who has Alzheimer's. Stage 2, very mild decline. Minor memory problems, lose things around the house. Things are easily explained away. It is unlikely to be noticed by family members. It may not even be noticed by the people who live in the home. So a husband may not realize what's going on with the wife, or vice versa. The reality is that usually at this point, you're still making excuses for why things are happening. You know, I forgot this. Well, I was tired, or I was busy, or I was stressed out. So it's very easy to explain away. In stage 3, this is when mild decline starts. Family members may start to notice and become concerned. There may be difficulty, your person with Alzheimer's may be difficulty finding the right word during a conversation. They may have difficulty organizing or planning events, or just planning their day, how they're going to get through something. They may have difficulty remembering the names of new people. Again, these things can be easily explained away. I've never been good with learning new names, or yeah, I've been having problems finding words in conversations for a long time now. So it's still very easily explained away. Family members may notice it, they may be a little concerned, but they don't really want to face it anyway. There's still some denial going on. So we don't really want to know if, does mom have Alzheimer's? We don't really want to go find out, because then, of course, their biggest fear may be realized. So mild decline may be noticed, but usually pretty easily explained away. Stage 4 is where things become more apparent. So they have difficulty doing simple math. And by simple math, it's like adding, 2 and 3 together. Poor short-term memory becomes more apparent. They can't recall what they ate for lunch, or they can't recall, what was said just 5 minutes ago. And this is where they start having trouble managing their own finances. Either they're not paying their bills, or they're double paying their bills. Maybe they're not paying some of their bills and not others. Maybe they don't remember they have this bill. So this is where family members really start to notice, because a bill hasn't gotten paid for 3 months. Stage 5, the person still maintains functionality. They can usually bathe and toilet themselves independently, so they can still go to the bathroom on their own. They still know who their family members are, but they probably don't know who everybody else is. They may have difficulty dressing appropriately. They don't know what the season is. They don't necessarily know that it's 97 degrees outside, so wearing a turtleneck is not going to be appropriate, or vice versa. It's January and it's cold outside. We don't need tank top and shorts. They may have an inability to recall simple details, such as their own address or telephone number, something they've known for a long time, but they have forgotten it. There is significant confusion at this stage. Usually, family members have you can't explain this away anymore. At this point, they've probably been diagnosed. If they haven't, then this is where diagnosis usually starts to be sought. Stage 6, this is severe decline, where they need constant supervision and require professional care. They're still able to move around. They're not bedbound by any means, but they don't, if they leave the house, they might not remember how to get back. This is where driving the car usually gets taken away. This is where you start fighting with them to take their things that they feel like they can still do, but for safety reasons, they can't do. They have no awareness of the environment around them. So they would walk out in the middle of the street, potentially, not realizing that, traffic is a serious concern. They have an inability to remember most details of their personal history. They may remember things from the far, far past, but, they might not remember when they got married. Or they might remember when they got married, but they don't remember when they had kids, that kind of thing. This is usually when they start having loss of bowel and bladder control. They don't understand what that urge means, so they don't attend to it. So they don't understand that urge when their bladder gets full, that they need to go to the bathroom. So they've now lost control of bowel and bladder. This is where the personality changes come. Like I said, they may become argumentative. You may see things in a person with Alzheimer's that you didn't realize they did. Your grandmother, who never cursed a word in her life, is now cursing everybody out. Your grandfather, who always loved his kids and always wanted to be around, the grandchildren, now doesn't want anything to do with anybody. So you will see major personality changes. People you did not know are now who your parents or who your person with Alzheimer's has become. They might start having behavior issues. They get aggressive. They become violent. This is where we start to really pay attention to how they react to certain things, because if you touch somebody with Alzheimer's and they aren't expecting it, they can turn around and swing on you, and they're strong. They might be older, but they're strong. So you want to make sure that you are paying attention to what they react to and how they react to it, so we can mitigate escalating behaviors. This is where they need assistance with bathing and toileting. They can't really do their ADLs anymore. They may be able to do some things, like if you hand the washcloth to them and help them initiate the act, by putting the washcloth in their hand and having their hands touch their face, they may realize they're supposed to wipe their face, but they wouldn't be able to initiate that complex behavior on their own. And this is usually when they start wandering, that aimless walking with no direction. They're just moving. And of course, stage 7 is very severe decline. This is the final stage of Alzheimer's, and they're usually nearing death at this point. They lose the ability to communicate or respond to their environment appropriately. So they may not be able to talk, but they may yell. May just groan loudly, but don't really say anything and don't really have a need. You've met all their needs. They've eaten. You've made sure they have a clean brief. They are not uncomfortable. The nurse has administered, some sort of mild pain medication to make sure that they aren't, stiff or sore, and they're still just groaning loudly because they can't do anything else, and they don't know that they're doing it sometimes. They may be able to utter a few words or phrases, but don't really make full sentences. And if you know them very well, you may be able to interpret what they're saying, but the average person would not. They have no awareness regarding their condition at this point. They are not aware of their surroundings or the interactions that they have with other people. They need assistance with everything that they do. They have no ability to take care of themselves at all. They may lose their ability to swallow, so they don't know how to swallow anymore. Their brain has forgotten how to swallow. And inevitably, Alzheimer's will always end in death. It is a terminal disease. Usually once you reach stage 7, depending on what's going on, the brain may forget how to breathe or how to keep the heart beating, and that's what causes a person with Alzheimer's to die. It may be an infection that causes the Alzheimer's to kill, maybe an infection that actually is what they die of, but in relation to it, Alzheimer's will be one of their causes of death. So let's talk about the difference between dementia and delirium. So delirium is a state of sudden confusion that is usually reversible. So unlike dementia, which is not reversible, delirium can be reversible. It can be triggered by an acute illness or change in a physical condition. So if you've ever heard somebody say your fever was so high you were delirious, this is what they're talking about. They were ill, they had a fever, they were talking or acting in a way that was completely out of their norm. We got the fever under control, the infection was treated, and they're back to normal. There's no residual effects at all. So this delirium can be life-threatening if it is not recognized and treated, but if treated, it can go away. Some symptoms of delirium: rapid decline in cognitive function, ability to think. They were fine 2 hours ago, and now they're acting like a crazy person, or they're acting like they don't know anything. They're swinging. They're not acting like themselves. Increasing confusion. They're disoriented to time and place. They don't know where they are. They don't know when it is. They have a decreased attention span. They're kind of all over the place. Poor short-term memory and immediate recall. They're not able to tell you back what you just said to them. They have very poor judgment. They're not able to see that doing something would be dangerous to them. They're restless. Like I said, they're very agitated. They have an altered level of consciousness, which means you may not be able to wake them up. They're very suspicious. People are trying to get me or trying to kill me. They may be having hallucinations or delusions due to whatever's going on. So yes, if this comes on all of a sudden, chances are it's delirium. If you go into a resident's room and they are acting like this, notify the nurse immediately. Stay with the resident to keep them calm or to keep them safe. You're not necessarily going to calm them down, but you can keep them safe. So you want to make sure, use the call bell, holler out the door, whatever you need to do in order to let your nurse know you need her in here right now because we need to get this taken care of. It may be a matter of calling 911. So we need to get them to the hospital because whatever's going on is above the care that we can give at a long-term care facility. If you're in the hospital, you may have to call rapid response and have rapid come in and deal with it because your person may have an overwhelming septic infection that was undiagnosed. So now we've got a life-threatening illness going on. You want to communicate with the resident who is showing signs of delirium, but you always want to stay calm. That's very important. If you get agitated, they're going to feed off of that and get even worse. Keep your voice normal. Don't yell at them because yelling will then be considered a sign of aggression and you could get aggression back. Use the resident's name. You may have to use it over and over and over again. You may want to try Mr. Brown, Mr. Brown. You may then want to go to their first name, John. You may try their first and last name, John Brown. Try to get their attention, get them to focus on you. Speak very clearly. You want to definitely give them short directions. Why don't you sit down? Or here, sit down. There's the chair. Lay down on the bed. whatever it is, you want to make sure that they are very easily understood and they do not take long to convey. Use your facial expressions and body language to aid what you need. You may want to gesture to the chair to have them sit down. You may want to, as they are starting to sit down, you start to sit down if that's possible. You want to reduce the distractions in the room because all of that sensory input can definitely play into this. They may not be able to focus, so they're overstimulated. So turn off the TV, turn off the radio. If there's somebody else in the room, clear the room of the other people. That way you can make sure that your person is safe. So dementia or delirium. They're often confused. Of course, like I just said, delirium is sudden, severe, and usually reversible, whereas dementia is progressive and irreversible. The resident who has dementia may experience delirium, so that it is possible for your dementia resident to become delirious, and you can correct that piece of it, but you will never correct the dementia. So let's talk a few key terms with Alzheimer's and dementia. Of course, cognition is the ability to think quickly and logically. Confusion is the inability to think quickly, causing disorientation and trouble focusing. Irreversible, a disease or condition that cannot be cured. Onset is the time when signs and symptoms of the disease begin. And of course, progressive is the way the disease advances. So of course, progression may be slow or fast or somewhere in between, depending. And sometimes we may not know when the onset of signs and symptoms started. Sometimes it's kind of vague and in the background. So your person with dementia, you think back and be like, well, there was that time a couple of years ago that this happened. Or you may be able to only say, well, I noticed last month that this, and this started, and that's what really got me concerned. So you may not be able to know when these signs and symptoms exactly started, but you may be able to give an idea of when you became concerned, when the signs and symptoms became apparent to you. With delirium, he was fine 3 hours ago. I came in here 20 minutes ago, and this is what I walked into. So onset for that would be, within the last 20 or 30 minutes. So dignity is respect and honor. Of course, everybody deserves to receive care with dignity. Independence is the ability to make decisions that are consistent, reasonable, and organized, having the ability to perform activities of daily living without assistance. Independence. We want them to live with independence, be as independent as possible for as long as possible. Quality of life is the overall enjoyment of life. We talk a lot about that when we talk about, how well are they living. And of course, respect is being treated with honor, showing appreciation and consideration. Of course, respect and dignity are forefronts of the hallmarks of person-centered care, so we want to make sure that we always provide care with respect and dignity, while encouraging independence and quality of life for the people we're taking care of. So every human is unique and valuable, therefore each person deserves understanding and respect. Dementia does not eliminate this basic human need. We want to make sure that we always give person-centered care, even if they don't necessarily know or understand that that's what we're doing. And of course, person-centered care maintains and supports the person regardless of their level of dementia. This is the same slide again. The resident's abilities and interests, preferences should always be considered when planning activities and care. So when you have somebody with dementia, you want to give them activities that mean something to them. They may enjoy doing puzzles. They may enjoy coloring. Someone who enjoys doing puzzles may not enjoy coloring. You have a lady with dementia who spent her whole life caring for her family. If you hand her 3 or 4 washcloths, she could stay busy for hours because that's what that's part of what she did for her entire life was, make sure laundry was done and laundry was clean. That activity right there gives her day meaning. So that's what we always want to make sure that we do when we start planning activities and keeping the resident taken care of, making sure that they're doing something that means something to them. And of course, as the disease progresses, we make adjustments in the care that we provide and the things that we plan in order to make sure we maintain dignity and respect for the resident. And it's important to know who the person was before the dementia started. So talk to the family, find out what they did for a living. You may have somebody who's a bricklayer. They were a bricklayer their whole life, so they may find something like Lego blocks very stimulating for them and appropriate for them. But that's not necessarily for everybody. So it's important to know what they were, so you can talk about who they were before they started with dementia. You can remind Mrs. Smith that she was a very powerful businesswoman, and that she did big deals all the time. And you can talk about things like that while you're taking care of your person, and give respect to who they are and who they were as a person before the dementia set in. So, of course, the individual's personality is created by his or her background, including their ethnic group, their culture and social practices, the environmental influences such as where and how they were raised and how they raised children, what their career choices were, what their family life was, what kind of hobbies did they like to do. Most people like to look at their grandparents and think they've always been this doddering old woman who just likes to bake pies, but in reality she was base jumping when she was 27 years old. So you just don't know. You have to ask, and you can't assume. So you can incorporate all of this information in the care that you give. We always want to encourage our residents to participate in their activities and daily care, but we don't want to set them up for failure. We want to set them up for success. You're not going to put somebody who doesn't like to do puzzles in front of a puzzle, because chances are you're going to end up creating frustration. And at that point, then we start talking about things like escalated behaviors, where the agitation gets worse and they become physically aggressive. So we want to make sure we set them up for success, of course, because we don't want to humiliate them. Humiliation is disrespectful and degrading, and it is likely to lead to that escalating behavior, that disruptive behavior that could put you or somebody else, including the resident, at risk. And of course, we want to promote independence rather than doing things for them. We want them to do what they can for themselves, and then we go back and make sure that it's done completely. So like I said, you may put the washcloth in their hand and ask them to wash their face while encouraging them to touch their face with their hand. So they may just wipe their cheeks. They may forget their forehead or their and so you would go back and be like, you did a great job. Here, let me get this piece that you missed. Let me get your eyes. Make sure there's no sleep left in your eyes. Things like that. We always want to make sure that we're praising them for what they were able to accomplish. We want to allow time for the residents to express their feelings and take time to understand what we are giving for them while providing emotional support. Long-term care facilities must provide care for residents in a manner and an environment that promotes maintenance and enhancement of each resident's dignity, respect, and quality of life. If we do not do that, then we are violating the residents' rights. And we do not want to do that. So communicating with the resident with Alzheimer's. Residents often experience problems making wishes known or understanding the spoken word. So of course this makes communication more difficult as the disease progresses. So things that you may see is the resident may have an inability to recognize the words or a phrase. They may not be able to name the object. They may know what a toothbrush is, and they may know what to do with the toothbrush, but they couldn't name the toothbrush to ask for it by name. Using general terms instead of specific words. So they may not say, I need my toothbrush. They may say, I need that thing to clean my teeth. They may get stuck on ideas and repeat the same thing over and over and over again. They may lose their train of thought. They may be inappropriate, silly, rude, or insulting. They may start using disrespectful language in conversations. Do not take this personally. They are not attacking you. Don't allow their language to offend you, because that's usually not the purpose of it. They will lose the ability to read. They will not be able to write anymore. They will lose that ability too. They will start combining language. So if English is a second language for them, they may go back to their native language and not realize it. We took care of a woman in a long-term care facility. She was from France. She'd lived in the United States for like 40 years. Her English was perfect until the day she stopped speaking English. And then she started speaking everything. She started doing everything in French. She understood English. If you gave her directions in English, she would do what you asked of her, but she spoke back to you in French. So as part of the care, one of the aides in that facility learned how to speak French so she could talk to her, so she could understand what she was talking about. So that is that one step above and beyond that you can do for the people you're caring for, should they do revert back to their native language. And of course, their levels of speech will decrease. They actually they only start using specific words, and you have to learn or kind of decipher what those words mean, what they're asking for, which means you may start asking them or showing them. They may say the word food and not be hungry. They may actually want something to drink, or they may say the word pencil and really they want to go to the bathroom. They may not be in any way, shape, or form related to what they actually want. So you have to kind of decipher what's going on. You may ask them and point and see if they, based on their body language or their responses, whether that's what they want. And of course, communication components. You want to definitely be patient with the resident, show interest in the subject that they're talking about, offer comfort and reassurance, give time for the pause. Make sure you give them time to respond. We don't ever criticize or correct. Usually if they're talking about something, we don't like to use the words, but wait, don't you remember? Because obviously they will not remember. And those words right there will cause frustration. So you just simply repeat it. It's not, well, we talked about this yesterday, because then that makes them feel like they've forgotten something. So we don't want to do that either. It's just a matter of, you just saying it again like it's the first time you've ever said it. We don't argue with the resident. The residents are right. There's no need to argue. You don't have to be right. Sometimes you want to guess at what the resident wants. Focus on the feelings of what's going on around them and not the truth. The resident may be yelling at you because they're frustrated with themselves. So the statement back could be, I see you seem you seem very frustrated. Is there something I can do to help you be less frustrated? It's about trying to make sure you meet their needs. Try to limit the distractions. Again, turn off the TV. And encourage nonverbal communication. Can you point to what you need? Sometimes we have picture boards, and those pictures, they can show you what they want in the pictures. So we want to encourage them to do things the way they can do them and to decrease frustration. Avoid interrupting the resident when they're speaking, because they're going to lose their train of thought. Always get their attention before speaking to them. Always make sure you have eye contact with them, because if you have eye contact, then chances are you have their attention. Address the resident by name. Approach them slowly. They may become startled very easily. Try to make sure you get to the same level as they're laying in the bed. Try to sit down in the chair, but try not to lean over them. They may see that as a threatening kind of action. Use a low, calm tone, pitch of voice. So you're going to want to talk to them slowly, very gently, very low. That way they can understand and have the ability to feel like you're not yelling at them or rushing them. Of course, patience and pacing are huge here. Definitely repeat as much as necessary using the same words and phrases, because that is usually how the resident will finally grasp what you're trying to tell them. Use nonverbal cues such as touching or pointing to start a task. Like I said, you may put the washcloth in the resident's hands and then gently lift their hands to their face to give them an idea of what you want them to do. We've gotten ahead of these slides here. Listen carefully when they respond. Monitor their body language. Sometimes when they get agitated, you're going to see it before you hear it. So monitor their body language. And of course, nonverbal communication is very important for the resident, the resident with dementia. If they don't understand what you have said, you've said it 2 or 3 times in the same way. Maybe you can change the way you said it, because obviously they're not getting it. So let's try breaking it down one more step. Maybe you've given them too many instructions. Maybe you've said, "Here's your washcloth, wash your face," and that's too much. Instead of saying, "Here's your washcloth," you just place the washcloth in their hand and then guide their hands to their face to get them to wash their face. And of course, we talk about the use of picture boards and books so the resident can point to what they need. We don't contradict the resident because, of course, then chances are you're going to end up causing a fight with a resident because then they may feel the need to be right. So we don't ever completely contradict the resident. Stay calm, be focused, speak slowly and clearly, use short words, one question at a time. Don't ever give them more than that. If you're giving them options, limit the options. Sometimes you don't give them the option. If you give them too many options, it's not going to go well. Then they won't be able to choose. Sometimes, would you like to wear the red shirt? They may say yes or no. Oh, so you don't want to wear the red shirt? Okay, then we'll wear the blue shirt. You didn't really give them a choice. You gave them the ability to decline, though, which still is giving them a choice. It's giving them the ability to control what they're going to wear, but without trying to force them to make a decision. If you hand up the red shirt, the blue shirt, the white shirt, they may not be able to choose what shirt they want. They may be able to tell you they don't want something, but they may not be able to choose what they do want. So you're going to want to limit the options you give them to minimal, to yes or no, usually. Definitely read through those sections just to know kind of what you should anticipate as far as communicating with the resident with Alzheimer's. Let's move on to slide 31. Dementia and Alzheimer's disease, keywords, behavior. It's how someone acts. All behavior has meaning. Keep that in mind. Everything that somebody does has a meaning behind it, even if we don't necessarily understand what it is. A catastrophic reaction is an extreme response. It's not what you were expecting, that came out of nowhere. Catastrophic reaction. A delusion is a false belief. Depression is the loss of interest in usual activities. Paranoia is an extreme or unusual fear. Sundowning is the increased agitation, confusion, and hyperactivity that begins in the late afternoon and builds throughout the evening. And we're going to talk about that a little more in just a minute. Trigger is an event that causes other events. Triggers. You're going to want to know what triggers your residents. If it triggers them in a negative way, you're going to want to do your best to avoid that trigger if at all possible. Of course, wandering, moving about the facility with no purpose and is usually unaware of safety. And of course, as Alzheimer's disease progresses through the stages, so does the behavior that goes along with the Alzheimer's disease. So of course, behavior is an observable, recordable, measurable physical activity. Somebody with Alzheimer's disease loses the ability to control those responses. Of course, the normal brain has the ability to control what's going on, but Alzheimer's, you lose that control. And of course, the behavior is a response to a need. So all behavior has meaning. So before choosing, behavior is response to the need. Let me go into that a little deeper. The resident is frequently unable to express his or her needs because of cognitive losses. So they can't really verbalize what they need from you. So they may act out in a manner that seems unwarranted, but they're trying to get something taken care of. So you have to be attentive to the gestures and clues. And the better you know your resident with Alzheimer's disease, you'll know what these gestures mean. So you could meet that need more quickly and alleviate the exacerbation of the activity. Sometimes the gesture or sounds will reveal what they want. And of course, as verbal skills communicate, behaviors become the way they communicate. So we have to pay attention to the behaviors because it's the only way they can tell us what they need. Of course, before choosing interventions to exacerbating behaviors, we have to know what the trigger is. So if the trigger is moving furniture, if the trigger is the visit of a specific person, if the trigger is a loud noise or the resident's too cold, the resident's too hot, we need to know that so we then can intervene appropriately. If they're too hot and we're putting blankets on them, then chances are the behavior is going to get worse, right? If the behavior is triggered based on a loud noise on the TV, then we haven't turned the TV off, we won't know that the resident is still being triggered. So of course, triggers can be environmental, physical, or emotional. Maybe the trigger is they're uncomfortable, and we need to then give them something to make them more comfortable, whether it's like an NSAID, a Motrin, or something maybe a little stronger. But the goal is to effectively manage their behavior so they don't hurt themselves or hurt others. And sometimes changing the environment can be the biggest trigger for them. So we don't move them from room to room. We try not to change their pattern. We try not to change their schedule any more than absolutely necessary, because that right there can be something that will trigger a catastrophic behavior that could then put the resident or the staff at risk. Some emotional triggers that we may come across include depression or frustration. Frustration is one that we see a lot. A change in self-perception if they're still cognitively able to have that. Sometimes it's a past life event. With Alzheimer's, sometimes things come forward that seem like they just happened that day. And of course, it can just be their personality. Maybe they always kind of overreacted. So maybe it's just normal for them to be overreactive. But you want to identify the trigger, understand the trigger, and respond to the trigger and adapt the environment to resolve the behavior. Because removing whatever that is can be what reduces the behavior. So we want to make sure the interventions meet the needs of the resident while maintaining respect and dignity. Because of course, preservation of residents' dignity is very, very important for us. It helps the staff gain confidence and improve morale and increase job satisfaction by having a successful behavioral intervention. You knew you could do it, now you've done it. So good job, right? That's what we want. We want you to be successful in handling a situation, meeting the residents' needs successfully, and making sure that they stay safe and that you stay safe. But don't be afraid to ask for help either. Sometimes you may know what Mr. Brown needs, and Nurse Susie needs you to help her with that, whereas somebody else, you may need help with somebody else. And of course, behavior control assists in the reduced use of restraints, because we don't want to do that. Decrease abuse and neglect. Again, if these triggers increase and exacerbate behavior, then somebody who is untrained may then respond with the same behavior, and then abuse happens. Or they don't want to go take care of them because, well, they're just going to act up and I don't want any part of that, so I'm just not going to go do anything. That's when neglect happens. And of course, if you are successfully able to manage behavior, the family is more satisfied and knows that you're taking good care of their family member. Let's talk about some common behaviors with Alzheimer's. Your book has a long laundry list of them. We're going to talk about a few. We talked about a couple that swearing, the sundowning, the wandering, the disorientation is common. They don't know who they are, where they are, or what the time of year is. They may have inappropriate sexual behavior, and that is very important to keep up with, because residents with Alzheimer's can become sexually aggressive. And that puts not only themselves at risk, you at risk, but it puts other residents at risk as well. So we have to pay very close attention to that behavior if it starts. They may have emotional outbursts that come out of nowhere. All of a sudden they're just sobbing or they're yelling and we don't know why. Inappropriate toileting, that would be peeing in a potted plant, peeing in the corner in the dining room. These are what we would consider inappropriate toileting. They may start doing things like shadowing, following other people. They may have sleep disturbances. They don't really sleep very well, or they sleep at different times during the day, so they may nap off and on all day. They may hoard objects. They may start hiding things, hiding pills, hiding food. They have a decreased awareness of their personal surroundings, which we're going to talk about in just a minute, which makes them a big safety risk. And of course, these catastrophic reactions that we've talked about, yelling, crying, striking out, this seems inappropriate to the event. So yeah, keep in mind that some of these behaviors can put you and others in danger. Let's talk about the safety risk. We're talking about wandering. Wandering is the known and persistent problem behavior that puts a person with Alzheimer's at high risk for safety, because they could fall, they could leave the facility, just walk right out the door and go away. They do run the risk of being attacked by other residents, because the resident may feel threatened. They may not only just wander in the hallways, they may wander into other residents' rooms. At that point, they've invaded somebody else's privacy. If somebody with Alzheimer's comes in contact with somebody who may be slightly cognitively impaired or maybe fully cognizant and doesn't like having them in their room, then you could end up with some sort of physical altercation that could put everybody at risk. The resident may wander for a lot of reasons. We don't really know, but it may be trying to fulfill a past duty like going to work. Maybe they're trying to get somewhere. Maybe they're just restless and they don't know what to do with the energy, so they just walk. They may be looking for where they're supposed to go. They may be looking for their room, their bathroom. They may be looking for their room at their home. They've been moved into a long-term care facility, but they're still trying to find their personal bedroom. So that may be what's going on. We don't really know what leads to wandering. We just know that it is a common behavior that we see. Things that we can do to help the wandering resident is to establish a regular route that's safe for them. Provide rest areas, which means you may want to make sure there's a chair available. That way, if they get tired, they can sit down. Accompany the resident, walk with them. Maybe try to have a conversation with them, see if they'll respond to you. My grandfather had Alzheimer's, and he was really bad for wandering. Make sure you provide for food or fluids. You may want to stop them on their route and offer them a drink of water or a snack. Redirect their attention to other activities if you can. And try to determine if it's due to stress. Do they wander after stressful events? Because if it is, if you remove the stress, maybe you can reduce the wandering. Let's talk about sundowning. This one is very interesting because you would think that the name would indicate that it starts to happen when the sun goes down, but it doesn't really change throughout the year. Of course, the sun goes down earlier in the winter, it goes down later in the summer, but sundowning tends to happen at the exact same time or around the same time for that resident. It's not the same time for all of them. But for that resident, you're going to notice about 3 o'clock things start to change. About 4:30, things really start to go downhill fast. The resident may become more agitated, less willing to cooperate. But the behavior makes it very difficult to get them to cooperate with anything in the activity. They get very hyperactive. They tend to be more agitated, and they really just, anytime you try to ask them to do something or get them to do something, you're going to meet resistance. The reason it's important to know this is you want to plan for the bulk of their activities when they're the best, which will be in the morning. So you're not going to try to give an Alzheimer's patient who has sundowners bath at night, because they're going to fight you on it. You're going to want to make sure you do everything when they're at their best, which would be usually early in the morning and before noon or right about noon. And then in the afternoon, they're quieter or less energetic activities, things that they may enjoy that may calm them down, like listening to music or letting the TV play on, not a high energy show. You're not going to want to put a show that has things exploding, but maybe something that is more even keeled. But generally, if you have somebody with sundowners, you're going to find that we don't know why it starts. We think it's because of fatigue, but it's hard to even say. Inappropriate sexual activity is another behavioral issue. This one becomes very concerning when the resident, if they become sexually aggressive. The offensive, inappropriate language, public exposure, so they may be masturbating in the dining hall, completely inappropriate, right? They may be getting naked in the activities room. Definitely have to respond to this. You cannot let this go unchecked. But it's very difficult because you don't necessarily know if they understand what they're doing or not. You always want to make sure that we treat them with dignity and respect. You're never going to treat them like a child. You would remove them from the public situation, assist them back to their bedroom or back to their room, maybe assist them all the way to their bathroom. If, maybe they have to go to the restroom. Redirect their attention to an appropriate activity. If you feel like the activity was due to the fact that maybe they did need to have, go to the bathroom, either empty their bowels or empty their bladder, assist them to the bathroom and make sure that they can take care of that need in a private situation. If they're in a room with another person, maybe the bathroom is the best place for them to take care of whatever sexual need they're trying to take care of. If masturbation is their issue, is the thing that you interrupted. Agitation is something we see a lot. It occurs for a variety of reasons. It's important to make sure that we keep the agitated residents safe. We don't crowd them because, of course, then they could view that as some sort of aggression on our part. If we need to make sure everybody else is safe, we need to get the other people out of the room. That's what we're going to do. We're going to get them out of the room versus trying to get the resident who's agitated out of the room. Ask permission before touching them. Always make sure you have consent before touching them, because if you don't and you touch them and you startle them, they could swing on you and then, knock you down or severely hurt you. We want to maintain a normal, calm tone of voice. Even if they're yelling at us, you're going to want to talk softly. Try to get their attention, redirect, lower the level of intensity. You're going to want to slow down what you're doing. Don't try to rush. Don't be agitated. You're going to limit the stimulation in the room. So turn the TVs off, get everybody else out of the room. Avoid confrontation or force. We're not there to prove them wrong. We want to make sure that they know that they are safe and that we're trying to help them. We're not here to force them to do anything. Avoid sudden movements outside of the resident's field of vision. They could take that as a surprise attack, and then they're going to attack. So when it comes to the agitated resident, you have to promote that calm front on your behalf, and make sure that you are maintaining your own personal safety. So you're never going to want to turn your back on an agitated resident. You're never going to want to put yourself in a position to where you have no escape route. Back to the door, hands at your side, feet shoulder distance apart, able to move whatever direction you need to move. If they sit down, you sit down. If they stand up, you stand up. You always stay at the same level of the agitated resident to help de-escalate the situation. And we actually get into de-escalation in module U. Oh, nope, we're getting to it. So yeah, always maintain, make sure you're safe. Get assistance if needed. Disruptive verbal outbursts are one of the residents' most persistent behaviors in long-term care facilities. Like I said, they may be moaning, groaning, yelling, hollering, crying, shouting, loud requests for attention. We had one resident that kept yelling, "Help me," all the time. And it bothered the resident, it bothered the visitors. The visitors would be like, "This woman down here, she really needs help. She's been yelling for 10 minutes. She's been yelling, 'Help me,' for 3 weeks." So the people who are in the facility don't necessarily understand. They feel like you're not taking care of the person, but that's not actually the case. These outbursts sometimes are repetitive. They are nonstop. It does not matter what you do. They still, they're still using these loud verbal outbursts. Residents may start with the negative remarks. They may start with name calling. Or they can be very, very verbally aggressive, using racial slurs, and they come up with some stuff that I've never heard, nor would I ever repeat. Don't take it personally. This is not about them coming at you. They don't know who you are. Don't take it personally. Anger and aggression are often visible symptoms of anxiety and fear. So this may be what you're seeing. They're anxious. They don't know what's going on. They're more confused today, and they're afraid. This may be why they're acting out. So it's important to try to figure out what's going on. While you're trying to work through interventions, make sure the resident's safe and that they, maybe you can redirect their attention, maybe assist them with things that they may need, such as toileting, feeding, or getting something to drink. Sometimes you have to move them out of whatever the environment is. Say they're in the activities room. You may need to move them to a quieter environment. But it's important to notify the nurse of aggressive behavior so that people can stay with the resident. At this point, they may need somebody with them 24/7 to make sure that they stay safe and that the other residents stay safe. Catastrophic reactions. Emotional, environmental, or physical triggers may result in a catastrophic reaction. So it is important to really kind of know what those triggers are so you can avoid them if at all possible. Because these reactions are so out of proportion generally to what's going on around them, we may not see them coming. The warning signs maybe, just a sudden mood change, or all of a sudden they're crying. Maybe they've just increased in agitation or restlessness. Maybe there was an outburst of anger. We didn't know, if you don't know what the triggers are, you won't see that coming. And then at that point, it's just going to continue to go up from there until you can get involved in the intervention process and try to bring it down to a better level. Same thing, speak softly and gently, reassure the resident, protect the resident, yourself, and others as necessary. Of course, you're going to want to make sure everybody is safe. Remove the person from a stressful situation if possible. If not, remove everybody else from the situation if necessary. We don't want to argue with the resident. We don't want to agree with the resident. I hear you. I understand. Avoid the use of restraints. You're going to do your best not to, physically restrain them in any way. Redirect the resident's attention to something more positive. Maybe it's, whatever the resident likes. Is it music? Is it a television show? Is it calling a family member? Sometimes that's what they need. They need to hear their family member's voice. Sometimes if the action or behavior, if the activity is what's triggering the reaction, you just want to change the activity and get them away from whatever's causing the overstimulation, causing the agitation, the catastrophic reaction. Of course, things that shouldn't include, we don't want to argue with the resident. We don't want to speak loudly to the resident or other staff members, which means we're not going to speak softly to the resident and yell at our coworkers. All of that's going to play badly. We don't ever treat the resident like a child. We don't ever talk to them like a child. We don't ask complicated questions. Don't ask them, well, why are you acting like this? Because they are not going to be able to explain that question. Don't ask them to explain their behavior. Ask them, is there something I can do, or would you like to do this? Give them yes or no questions. They're probably not going to be able to answer anything more than yes or no, quite honestly. And we don't use force, and we don't command the resident to do something, because chances are that's going to give you the opposite effect of trying to reduce the intensity of the behavior. Of course, we want to maintain calm, a non-controlling attitude. We want to speak softly and calmly, answer one question at a time and wait. Ask one question at a time and wait patiently. Use simple one-step commands, positive phrases. Avoid crowding the resident, of course, which means if you need assistance, then you only need as much assistance as you minimally have to have. You don't want to put 6 people in a room when you can do it with 2. Because again, that is going to then lead for the resident to feel even more agitated and more in fear, which will just escalate the situation even worse. Sometimes providing a distraction can help, such as an activity or music. Again, find out what the resident likes, and at that point, you can maybe use that to your advantage. This is where the day-to-day relationships come into play with de-escalating behavior. Because if you know the resident day-to-day, then you can use that to your advantage and leverage it to help get them what they need, so then you can calm the situation down before anybody gets hurt. The goal with the care of the residents is to give support that is needed so that they can participate in the world around them to the best of their ability. We're not trying to force them to do life the way we think they need to do it. We want them to interact life the way they want to interact, that gives them the best quality of life that we can. So we want to focus on the fact that the resident is involved and satisfied, and not necessarily on the task or activity that they're doing. And of course, doing activities keeps the person busy, but meaningful activities have value to the resident. And we as the staff are not the ones to dictate what gives the resident value for the activity. We let the resident tell us that. Of course, activity-based care is focused on assisting the resident to find meaning in his or her day, rather than just doing activities to keep the person busy. So sometimes that works for a little while, but in reality, if they're just doing something just to be busy, they're going to get bored with it pretty quickly. But if they're doing something that gives them meaning, then they'll stick with it longer. They'll probably be engaged with it for a longer period of time. The principles of activity-based care focuses on giving the caregivers the tools to create chances for the resident with dementia to be successful in their activities and their relations with other people. We want to use any daily activity that can be broken down into individual sequential steps. So things that can be done step 1, step 2, step 3. We want to definitely work with the remaining strengths of the person with Alzheimer's to create successful interactions and reward the residents' attempts in participating in the activities with a sense of being capable being capable and alive. They're still here, they're still living, they're not just existing. Of course, we want to time the activities to when they're at their best. We don't want to definitely put a sundowners person trying to do activity-based care in the afternoon, because that's not going to go well. So set the time based on the person's routine and when you're going to get the best participation and satisfaction out of the activity. And of course, maintain the cultural values and beliefs. We want to make sure that we are promoting a positive environment, which includes inclusion of the resident, making them feel important in their relationships and daily activities. Let's talk about burnout real quick. When dealing with someone with Alzheimer's, burnout, or nurse aides in general, burnout is a huge problem. So you want to make sure that you understand how this plays and affects you as a person and as the nurse aide, because what happens at work sometimes go home, and we don't want that to happen. We want to make sure that you understand that the stress at work, you need to have an outlet, and it needs to be a healthy outlet. So because the population is more prone to becoming, the population of residents, the Alzheimer's population of residents, they're more prone to becoming victims of abuse and neglect because of nurse aide burnout. In regards to the cause, the nurse aide must take the necessary steps to ensure that you do not react or overreact negatively to the resident's behavior. Frustration on the nurse aide's part can lead to negative, harsh, or mean-spirited statements made to the staff or the residents. So you not only would take it on the residents, you take it on the people you work with. It can come out in the form of verbal or physical abuse, emotional abuse of the residents, and neglect of the residents. And we don't want that to happen either. So it's always important to remember that statements and behaviors made by the resident with Alzheimer's are not directed at you personally. They are not meant to hurt you directly. They aren't really in control of what's going on. So be very, very careful that you don't become part of the problem and let stress and burnout affect the care that you give to the person. So if you are the type of employee, or you become the type of employee that takes work very seriously and very personally, everything that happens you have personal stake in, if you're working over at the end of every shift, if you're working extra shifts, which of course leads to a lot of increased fatigue, you're taking on extra projects, you have very unrealistic expectations of the job that you can do. I'm going to meet the need of every person every day, all day long. Not being able to meet that expectation weighs very heavily, makes you feel like you're a failure. And of course, somebody with a perfectionist attitude doesn't really handle that very well. So all of these things lead to increased burnout. Signs and symptoms of burnout include you just no longer want to go to work. If you're earning time off, like if you're earning sick leave, oh, I got 8 hours on this last paycheck, I'm not going to work tomorrow. If you are earning and burning leave, you have burnout. And you are not going to be very effective at what you do. So if you no longer enjoy work, if you get irritable with the people you work with and the people you care for, that's not a good thing either. If you have a sudden fear of failure or an inadequacy of, losing your job or the obligations to your supervisor, you're not able to meet all those demands, then you've got too much going on. If you feel overwhelmed, if you view work as a chore, I don't want to go do this because it's just not fun anymore. If you are frequently feeling ill, like you constantly have headache, your backache, you just don't feel good at all, you are suffering or showing signs of staff burnout. That means you need to do something about it. You can't just continue to carry on like this and go for it. You have to do something about it. Pushing through at this point is not necessarily a good thing. So things that you can do to prevent staff burnout: maintain good physical and mental health. Be active outside of work, even if it's just walking or going to the gym, whatever you like to do for physical activity. Be in good physical and mental health. Get adequate amounts of sleep on your days off and before your shift. If you're up until 4 o'clock in the morning trying to do this and you're getting back up at 6 to go to work, or if you're working a lot of doubles and not getting any sleep at all, these will lead to burnout. Don't do that. Definitely use your days off. Take rest on your days off. Make sure you're getting enough sleep. Remain active within your family and community. You need friends outside of work. Don't just let the only people you ever talk to or hang out, be the people that you're at work with, because when you're together, all you do is talk about work. You want to have friends that don't work in the field. You want to have friends that do other things so you can talk about other things. And maintain a sense of humor. Sometimes laughter is the best medicine, and it is the only medicine that you have to give to yourself. So be able to understand that sometimes you just have to laugh about it. It's a terrible situation, but if I didn't laugh, I would cry. Sometimes that is the stance you have to take. Sometimes that's what you have to do. And it's not, doesn't react negative, doesn't mean you're a bad person. It doesn't. You will hear, and it happens a lot, and it is very true, medical professionals have very warped senses of humor. And we do, because it's how we maintain our sanity. Sometimes you have to learn where your barrier is, what you can do, what's your boundary, and then you don't step over it. Because if you do, then you've gone too far, and burnout is on its way. So it's important to know when you need to pull back. One of the things that we as healthcare providers tend to fall in the bad habit of is overtime. There's a lot of money to be made in overtime. And if I just worked a little bit of overtime, then I could pay for this. Well, then that money becomes, well, if I continue to work overtime, then I'll be able to do this. And you'll find soon that all you do is work, and you're always tired, and you're tired of going to work. And then you're doing a bad job, and you're dodging what you're supposed to do, and you're not doing you're not doing what needs to be done, and you are impatient with everybody. And that is burnout. So don't fall in that trap of, I'm just going to work overtime. It's going to be great. I can work 6 days a week. It'll be fine. It'll be fine. I can do this. After a while, it wears on you. Sure. Could you do it for a little bit? Absolutely. Could you do it for a long period of time? No. Most people tend to suffer burnout much more quickly. If you are suffering from burnout and it's because of the place you work, maybe it's time to move employers. Maybe the place you work is part of the reason you're stressed out and burned out. It's not you, it's the place where you work. So if the management is bad, if the staff is bad, if there's the whole facility, everybody is bad, it's okay to say, this isn't the environment for me. I'm going to work in a different environment. Not everybody is set to work home health. Not everybody is set to work long-term care. Not everybody is set to work acute care. There is a place for everybody. And you may find that, the acute care facility is not for you. I don't like the hospital. There's too much turnover. I much prefer getting to know the people that I take care of. Long-term care is for me, or home health is for me. Maybe you're somebody who has a very special knack, and hospice is for you. Again, hospice, you tend to run into a lot of burnout there too, because the death and the grief is just overwhelming. So make sure that you know where your line is, know what burnout looks like, and know what you need to do, strategies to prevent that burnout. Hopefully this is helpful, and that is the end of Module T.